You can begin.
Welcome back, everyone. Our next panel is moderated by the illustrious Dr. Debra Toney, who is president of the National Coalition of Ethnic Minority Nurses, or the president of the National Coalition of Ethnic Minority Nurse Associations, actually even more broad. And I think it's fair to say that that position has come to her through a combination of over 30 years of clinical and leadership experience in nursing and healthcare, and a passion for ethnic minority health disparities or health issues, which often involve disparities. So with that, without further ado, I'll turn it over to Dr. Toney to lead our next segment.
Good morning. Well, at least this morning here in Las Vegas. So bringing you greetings from Las Vegas, where it's a little chilly. But thank you. It's great to be here, and I'm looking forward to introducing you to some phenomenal leaders who are part of NCEMNA. But NCEMNA is the National Coalition of Ethnic Minority Nurse Associations. So NCEMNA is an association of associations, and we have a 21-member board of directors. Our members are Dr. Norma Cuellar, and I know I messed your name up, Norma, who is the immediate past president of the National Association of Hispanic Nurses, as well as a professor of nursing at the University of Alabama. I have Dr. Martha Dawson, who is the president of the National Black Nurses Association and associate professor of the University of Alabama, Birmingham. Dr. Lillian Tom-Orme, who is a past president of the National Alaskan Native American Indian Nurses Association and a research assistant professor of nursing at the University of Utah. And I think you're in the School of Medicine, right, Lillian?
Yes.
Yes. We have Dr. Alana Augusta, who is the immediate past president of the Asian American Pacific Islander Nurses Association and associate professor of nursing at UNLV, which is the University of Nevada here in Las Vegas. And then we have Dr. Mary Joy Garcia Dia, who is the president of the Philippine Nurses Association of America. And I'm sure you all know that your own Dr. Enoch M. is the current president of the Asian and Pacific Islander Nurses Association. So NCEMNA is a coalition. We come together on issues that are important to all of us. Some of our associations are large, some are small. But what I can tell you is that we represent 1 million ethnic minority nurses in this country. And you'll get a chance to hear from the phenomenal leaders. I don't want to give too much away, but our mission is to come together and advocate for equity, the elimination of disparities in healthcare. So with that, we will just kind of jump right into it. We'll leave a little time on the end for some questions, and also reminding our panelists, because like I said, they are phenomenal, that you get about 2 minutes, 2.5 maybe. So the first question, and it's not a question, but we do want to give you an opportunity to introduce your organization very quickly. So Dr. Dawson, we'll start with you.
Good afternoon. The National Black Nursing Association mission is to serve as the voice for Black nurses and diverse populations, providing equal access to professional development, promoting educational opportunities, and improving the health of our Black and Brown communities around the world. We have 114 chapters in 35 states and the District of Columbia. NBNA has over 4,000 members, and 74% of our members are RNs, 3% LPNs, and 23% are nursing students. 86% of our members practice in hospitals, and 86% of our members also have a doctorate or a master's degree. And at least 13% of our membership is made up of nurse practitioners and nurse anesthetist.
Okay, thank you for that, Dr. Dawson. Dr. Garcia Dia from the PNA.
Hi, good afternoon, everyone. My name is Dr. Mary Joy Garcia Dia, and I represent the Philippine Nurses Association of America, which was established in 1979 and was primarily driven by issues surrounding Filipino American nurses who have faced discrimination and immigration issues. So 5 chapters came together from PNA New York, Southern California, Illinois, and New Jersey, and Michigan to form the now PNAA. We are a 501c6 nonprofit professional nursing organization representing 55 chapters with over 5,000 plus members in 43 states. And we celebrated our 40th anniversary in Atlanta, Georgia in 2019. We offer our members mentorship, leadership development, and educational programs for their professional advancement. And we have over 20 committees comprised of education, practice, and research as well. So we are so glad to be part of this discussion to understand what's going on with our Filipino American nurses during the state of COVID.
Thank you, Dr. Dia. Dr. Anagasta from APINA.
Hello, thanks Dr. Toney, and thanks everyone for joining us today. Thanks to the Emory University School of Nursing for giving this opportunity, Dr. Im and Dr. McCauley. So the Asian American Pacific Islander Nurses Association National was established in the early 90s. It is one of the smaller organizations compared to the other ethnic minorities here. APINA, in short, was also the founding organization for NCEMNA. APINA's mission is to serve as a unified voice for Asian Americans and Pacific Islanders nurses around the world. APINA strives to positively impact the health and well-being of Asian Americans and Pacific Islanders and their communities by supporting its nurses and nursing students around the world through research, practice, and education, facilitating and promoting networking and collaborative partnerships with national and international organizations, and influencing health policy through individual and community actions. APINA has grown steadily, more so since 2018. We now have several chapters, including Hawaii, South Carolina, Nevada, and international chapter in South Korea. We also have 3 Student Nurses Association chapters, 2 in Nevada and 1 in Vanderbilt University. Several efforts and initiatives have been accomplished by most of these chapters to meet the mission of APINA National. Chapters are crucial because they extend APINA's work and serve as conduits for our national organization. Just to give you a brief profile of APINA, most of our members are employed in academia. They are educators and nurse researchers. Majority of our members have graduate degrees, PhD, and some have dual degrees, master's and bachelor's, and also Doctor of Nursing Practice. Thank you.
Thank you. Dr. Tom-Orme.
Good afternoon, thank you. So my name is Lillian Tom-Orme. I'm representing the National Alaska Native American Indian Nurses Associations, and we represent 574 federally recognized tribes, and then additional state recognized tribes. We've been in existence under several names since 1970, and we reorganized in 1993 as the National Alaska Native American Indian Nurses Association, or NANA-INA. We're currently based in Minnesota as a 501c3 organization. We're a member of NCEMNA. We also have partnerships with AARP, Indian Health Service, University of Minnesota, St. Catherine University, as well as University of Wisconsin, where we just had a nursing summit last week. We have members coming from all parts of the country, but we do have some groups. We don't have chapters, but we have some members coming, usually as groups from nursing schools in Alaska, Wisconsin, Minnesota, New Mexico, Arizona, South Dakota, Oklahoma. According to HRSA, the American Indian Alaska Native nurses make up 0.3% of the total nursing population. So our numbers are small, and often we're grouped under other, and that's not something that makes us happy. We need to make sure that we've got numbers and we have our own name when we get these national nursing reports. Thank you.
Thank you. And Dr. Cuellar?
Thank you. I'm very happy to be here, and thank you to Emory and Dr. McCauley and Dr. M for organizing this. It's been a wonderful conference thus far. My name is Norma Cuellar, and I'm representing the National Association of Hispanic Nurses as the past president. We started in 1975 by a group of Latino nurses who felt like ANA wasn't meeting their needs and they wanted to break away and develop their own organization. Currently, we have 47 chapters across the country. We are a service organization with 1,800 Latino nurses, or you can be a person interested in the health of Latinos. So you don't necessarily have to be Latino to be a member. At this point in time, Latinos make up about 10% of the nursing workforce. However, Latinos are 18% of the population, so there still is a disparity there. We're active in health policy. We have our journal is Hispanic Healthcare International. In the September issue, myself as past president and the executive director, wrote a brief report about everything that NON had done in relation to COVID-19. We did 8 sign-on letters. We did the administrative activities, including providing bilingual resources. We included mental health resources, social media, and the support from other organizations. So if you get a chance, check out that article and to hear more what NON's doing. Thank you.
Great, thank you. So you all can just imagine what a powerhouse this organization is when you have leaders as such in a board meeting. So covering all areas, and I believe it was Alana who had mentioned that we have organizations that they're one of our smaller organizations. But when we come together on those joint needs, we are a powerhouse. And I really like to emphasize that, and that the representatives you see here today are the authentic voice of ethnic minority communities, ethnic minority nurses in this country. So today we're going to talk about the implications for research as it relates to COVID-19, which has really taken over everything. A lot of us are on the front line, first responders, academicians, etc. But right now the US is experiencing the worst public health crisis in a generation. I mean, there is not one area that it has not. But this same crisis has taken us to new heights. And as Norma just mentioned about the research and that type of thing that's going on. So I have a few questions. We're going to limit those questions to 2 minutes, and we'll just start right now. So the first question is what are the impacts of COVID-19 on your population, whether it be microaggression, high mortality, etc.? And we're going to start with Dr. Garcia-Dia.
So when the pandemic hit New York, New Jersey area at the time, we know that we need to do something about it. We established the COVID-19 task force, and I have to step in temporarily as the president of the Philippine Nurses Association of America, because our very own president, Madeline Yu, was affected by COVID. And similarly, her husband also suffered from COVID and eventually died. We were very concerned because it hit us personally. Our members, according to a survey done in 2017, reported that majority works in acute critical care area, medical, surgical, and geriatrics. A significant number are also advanced practice nurses and clinical nurse specialists. And we know that it's taking an overall toll on the emotional component of our members. Many of these nurses go unnoticed as they take the most dangerous tasks in COVID-19 units, like bathing, suctioning intubated patients, and comforting those who are dying without family present. Many of our Filipino American nurses work extra shifts, just like many of our nursing colleagues, as the healthcare system was overwhelmed with the unprecedented surge of inpatient admissions and the acuity of patients needed critical care. So obviously there was a lot of emotional distress and a moral injury that our Filipino American nurses have suffered through. And this is a great way for us to really focus on the workforce and understand what is the overall impact, not only during that time, but the repercussions on our resilience as nurses.
Thank you. Dr. Dawson?
The National Black Nursing Association has really been monitoring this from the beginning of this pandemic. Relatively to the virus, we as African Americans and Blacks in the United States, we have a larger percentage of those that have contacted this virus. We also have a higher incident of pre-existing conditions that make our recovery from this virus less likely. So 1 in every 1,000 African Americans that contact COVID generally end up expiring from this disease. So we're dying twice as much as whites, and about 79% of the children that have also had contacted COVID are actually African American children. So one of the things that we continue to see is that our employees are on the front line. They're also contacting this, maybe not as much as some other race and ethnicity, but still at a very alarming rate at this time. Our older adults that are in nursing home are also experiencing, a much larger percentage of deaths. They're staying in the hospitals longer, they're on the ventilators longer. And then there's this economic impact on our population, meaning that we don't have the economic resources. More African Americans are considered to be frontline essential workers, whether we are talking about nurses or those individuals that are working in restaurants, individuals that are also working in transportation, whether you're talking about the driving the large trucks to deliver food, driving buses, managing the subways, and some other places that we are also dealing with now is your food sources. Whether you're talking about, desert food sources within communities. Also, when you're looking at the fact that now you're seeing more and more individuals, not just African Americans, but other races that also need to rely on, food pantries that traditionally may not have seen such a large increase. But with this pandemic, these individuals now are almost serving not just maybe hundreds of thousands a month, but they're up to the 300,000 and 400,000 and 500,000 a month. So we're definitely being hit very heavily in terms of the economic impact. And many of our families, again, are also helping out families that may have been furloughed from their jobs, lost their jobs. And again, many of us are in the low wage earning category. So many of our people are not bringing home, the level of income that other may have savings, and we just don't have those savings. So it's impacting the Black and other brown communities much heavier than it is the major population.
Thank you. Dr. Angosta, how is this impacting the Asian Pacific Islander communities?
So it's well documented in the literature that Asian Americans and Pacific Islanders have high prevalence of cardiovascular risk factors and other chronic conditions, such as diabetes, hypertension, liver and lung diseases that can lead to COVID complications and increased morbidity and mortality. In addition, mental health disparities exist in these populations, which have been amplified by the COVID-19 pandemic. According to current reports, Asian Americans and Pacific Islanders have more complications from COVID-19 when compared to other populations, and many are dying from it. Asian Americans also, and Pacific Islanders also have underlying heart diseases, and the issue is that many of them are very afraid to go to the clinics and to take care of themselves because of the fear of COVID, and many of them don't have transportations. Many have lost their jobs and also health insurances. The current literature also indicates that COVID-19 pandemic has amplified discrimination and racism across the United States, including xenophobia, in microaggressions. Hate crimes, physical violence, and harassment have intensified among Chinese, Japanese, Koreans, and Vietnamese, and Taiwanese, particularly when President Donald Trump called the COVID-19 the Chinese virus and other names associated with Asians. In fact, there was a spike in violent crimes against Asian Americans in the United States during that time, according to Campbell and Ellerbeck's 2020 report. Also, the use of social media has reinforced prejudice and stigma and intensified discrimination and hate crimes during the COVID-19. Many Asian Americans have professions and jobs that are considered essential. The risk for COVID-19 exposure is high for healthcare workers, physicians, nurses, dentists, and pharmacists. All put them at risk for COVID-19 exposure and burnout. For example, working mandatory shifts and overtime. Many Asian Americans have small businesses. The COVID-19 has caused many people to lose their businesses and thus income. With regard to cultural perspectives, many Asian Americans have negative perception of conflict. According to the literature, many do not like to argue and have the concept of preserve harmony at all costs, which can be problematic, particularly during this crisis for nurses and other healthcare providers whose employers, for example, do not provide adequate and appropriate level of personal protective equipment, which put them at high risk for viral transmission. Also, the fear of insubordination or losing job, for example, if they complain about lacking personal protective equipment at work. Another cultural consideration with Asian Americans and Pacific Islanders include living with extended families and caring for their elderly, which can pose a risk for COVID transmission and exposure. Others include health and religious beliefs, particularly self-treatment with herbal remedies, and some may even believe that God will take care of the problem more than the infection control measures. Social determinants of health have been a chronic issue also among Asian Americans and Pacific Islanders. The model minority myth is a myth, and according to the literature, that doesn't exist anymore. Poverty.
And Gosta, I'm gonna have to call you out right now.
Yeah, so I'm gonna finish this. Another important issue that we need to understand is mental health among Asian Americans, Pacific Islanders, particularly the nurses and communities. Thank you.
I'm gonna have some more questions here for you all to get it in. Dr. Tom-Orme, you know, I know there's a lot going on in the Native community. Can you just share with us briefly some of the impacts of the community?
Okay, thank you. So with the American Indian Alaska Native population, we certainly have suffered, you know, all the aforementioned issues. You know, you probably read in some national or maybe even international reports about the high rates of COVID infections in our populations. I've read through the New York Times and other papers where the Navajo Nation had the highest rates in the country. You know, when you pull in even 13 states together, or maybe 5 states that include New York and New Jersey. So we really were unprepared, just as many of the organizations and healthcare providers were unprepared for this. Because we have a political relationship with the U.S. government, we are identified as sovereign nations. So right now we have 575 federally recognized tribal nations. We do have a relationship where our people do have, I will say, access to healthcare services, but often that's very problematic, very slow. Therefore, we were really slow in getting the necessary PPEs for the hospitals and care centers. In fact, the tribes were asked to write grant applications and compete with one another to get funding for PPEs and for care, and at which point the tribe said, no, we will not compete with one another. We have this relationship with the U.S. government. And so, you know, finally, that's how they received the funding. So there is quite a bit of that, just a lot of political issues, you know, those kinds of things that seem like are part of this process of trying to get health care. We have had really high rates in some states, for instance, in New Mexico and Arizona. The Navajo Nation straddles those two states, and we saw a lot of morbidity and mortality. One of the most recent CDC reports that our younger population were affected, in fact, at 13% versus 4% among the whites in general across the country. And then our older people were infected at 12.6% versus whites who were 28.6. You know, that was kind of hard to believe, but apparently that number is due to having smaller numbers of elderly people. But we did lose a lot of elders, and when in our populations, if you lose elders, you are losing an encyclopedia or a history book, because we look to our elders to have the oral traditions. And then, I mean, I can go on, and one of our main problems is lack of data. CDC just recently reported that among laboratory reports, we were severely lacking descriptions about symptoms that people were reporting, hospitalization status, ICU admission, death. So it's just, you know, we're trying to resolve some of these kinds of issues as we go along.
Well, thank you very much. So, Dr. Cuellar, what are the impacts of COVID-19 on your population? And we're gonna tie this into the next question. And what do you consider in providing care to your population? Now, that doesn't mean you get 10 minutes. It means you get maybe 3 minutes. You're on mute.
There you go. I said I better hurry then. So I think you can hear from everybody how we all have different perspectives of the damage that has been done to our populations. And we've all been hit very hard. And one of the reasons is because COVID is like a wave. It goes through the country and it goes around, and whether it's in the Midwest or whether it's in California, or, you know, so we all have our numbers, and they change every day because COVID is changing every day. At any one time, Latinos have represented 20 to 30% of all the cases. There's disproportionate examples. For instance, in California, there's 39% Latinos, and yet there's 61% cases of COVID. The hospitalization rates for Latinos is 4.4 higher than whites. And we know that about 22% of COVID deaths are all Latinos. According to the CDC, Latinos have 2.8 times the amount of cases, 4.6 higher in 4.6 in hospitalization. So we know that there's many issues related, and many of them are the social determinants of health, and we can all relate to those factors. We have issues related to housing. We have issues related to work settings, how Latinos work. And different factors related to that. Related to health equity issues, everyone should have the opportunity to attain full health, and no one should be disadvantaged, and yet we see all of our groups in that specific condition. Minority and disadvantaged communities, and that's pretty much all of us, we all have increase in comorbid conditions. Immigration status is a big problem, language barriers. And like I said, the poverty rate or employment and the poverty rate, especially in Hispanics. This morning, someone asked about how to inform communities of COVID-19. And one of the things I would say that is a strength of all of our groups is that we are very community-based. We are in the community. We work with our community. For it's with Latinos. You have to have trust to get into the communities to teach people about immunizations or about what they need to be doing about COVID and talking to them about the problems. So all of our organizations are really hands-on. We're working very hard to help with that problem. That's where we're at. And what was the second part of the question?
Was what do you what do you consider? What are you doing to provide this care? Based on different cultural values and attitudes.
Yeah, I think I went over most of that, so I think I'm good.
Yes, you did. So thank you so much for that. So really, we're going to jump into where the rubber meets the road, and that is research. We are hearing a lot about research. We're hearing even now about the COVID vaccines. I think everybody's doing personal surveys on COVID vaccine. My husband says, I'm taking it. I'm saying I'm not taking it. I need more data. So there's all types of conversations that are going on. But for you as researchers, academicians, frontline providers, etc., this question is what do you consider when you're conducting a research study among your population doing COVID? What are some of those issues? How are you going to recruit? And really, I think most of you mentioned the trust and some of those type of things when we start talking about how are we going to get people to trust us well enough. And even myself, first thing I said is I need more data, babe, before I start talking about taking some shots. So how will you handle that? So let's see, we'll start out with Dr. Tom-Orme this time, trying to move it around a little bit.
Okay, so research is that R word when you go into American Indian, Alaska Native communities. People don't want to be researched. They don't want to be put on under the microscope. And this is because they have a long history of distrust with particularly early on government officials coming around, taking information, and then later universities coming in and wanting to poke at everything. And then there are even some more recent documentation of how they were unaware of participating in a study that they had not signed up for. Universities coming in, taking blood for mental health or issues when they really signed up for a diabetes study. These kinds of things have created distrust in our population. So we do have IRBs in some of the larger tribal nations and some of the smaller ones. Usually the tribal government will provide information about how to go about doing research in their communities. So what researchers do when they come in is to make sure that they're meeting with the appropriate people, the appropriate body that approves research, and then make sure that the community is informed, that the community is involved in research from the beginning to the end. And I know with my tribal nation, which is the Navajo Nation, we were one of the first to develop an IRB, and it was served as a model for many of the tribal nations. And what is expected of us is every month we have IRB meetings, and we're expected to share everything, including the consent forms and how we might have to translate that for people who may not read English or speak English very well. We are asked to share any reports that come out of research, any publications, any presentations that we might be making about the particular tribal nation. And so there's quite a bit of that to go through. Right now, though, some of the tribes are still shut down. For instance, I'm in Utah, but some colleagues and I are working with some small tribes in eastern Nevada. we cannot go out there based on travel restrictions from our university, plus they're not wanting outsiders to come in at the moment. So our research has come to a stop at this point. And then down in the southern part of the state, we have the Navajo Nation, and we're also doing some environmental health studies. So we're just kind of waiting to get back in. So it's very difficult at this point. But there are a lot of issues that I think, you know.
Tom-Orme, I'm going to jump in. They're giving me the signal.
Okay, all right, I'll stop.
Save a little time if we can get through everyone, and then hopefully we'll have a little time where you all can
Okay, I'll stop.
So we're going to move on again, thinking about research and the implications and how can we. I think all of you have mentioned some of the same things. Dr. Dawson, I'm really interested in what you're going to say.
But one of the things that, first of all, we like to think that the National Black Nursing Association members are indeed the most trusted members within the community. Not only because of this COVID pandemic, but we have been in the community for years. Ever since this organization was formed 49 years ago in 1971, we have actually used a collaborative community health model that was actually developed by two of our past presidents, Dr. Linda Burns Bolton and Dr. C. Alicia Georges. And this framework actually provides us a footprint on how to engage the community and others within things that we are trying to achieve with our population. So for example, we have an extensive network and partnership. Some of the things that our nurses have been out there doing, again, is the same things that have been mentioned already. But just to give you an idea of the extensiveness of our relationships that we have in the community is, you know, thank goodness, you know, Pfizer is one of the ones that are trying to create this vaccine. We've had a long-standing relationship with Pfizer. We've had a long-standing relationship with VITAS, which is a palliative care organization that have had a unique role to play during this pandemic. And in addition to that, we have CBS as one of our partners. And as they're talking about pushing out this vaccine, you keep hearing them talking about, you know, CVS and Walmart will be on the front end of that. So our goal have always been to spread our wings and make sure that we have partners not only within the profession of healthcare and nursing, but also in other spaces as well. But one of the things that I'm extremely excited about is early on in this pandemic, we was also networking with other social entities. So for example, we actually collaborated with the National Black Medical Association and the Rainbow Push Foundation and to actually develop a manifesto. And in that manifesto, we talked about what people needed to do to protect themselves. We also talked about things such as, we was on the front end of talking about what would happen when they started about opening schools and sports. We was also pushing the envelope saying, but what about our prison population? What about our young people that are in the, again, in the system somehow, the juvenile system? Who's taking care of them? But most recently, as of 2 weeks ago, I started collaborating with a new group called, this is really the Black Coalition Against COVID. And this coalition is made up of the 4 historical African-American medical schools. That is Morehouse, that's Meharry, that is Howard University and Drew University. And so we have been pushing out information relating to the COVID-19 vaccine. And one of the things that I'm so proud of is that we've also just last week, we actually released what we call a love letter to the Black community. So it is a love letter to Black American talking about, so we understand about the Tuskegee, we understand about the research, and that many of us are very leery of research. But we want them to know that it's not just even just the Black nurses and the Black doctors, but we have the Black lawyers with us as well. And we're trying to say, we're out there in the media, we've already reached in that 2 or 3 weeks time period, over 1 million listeners, just listening to us talk and give them information. We talk about 20 minutes and they have about another 30 minutes to ask us questions. So we really are trying to engage the community, ask them, what's bothering you? Tell us, you ask us the question, let us respond back to you.
Thank you so much, Dr. Dawson. So, Dr. Cuellar, I know you are, I know I mess it up every time. We know you are a renowned researcher, so we'd be interested in hearing what you have to say about conducting research. You know, how we all know that everybody, the first place people want to go, I work in an FQHC, a Fairly Qualified Health Center. Every time we look up, somebody wants to come and start experimenting, and that's what the patients think in underserved communities. So share with us, you know, what should that look like?
So research with Latinos and COVID-19, if you do a review of the literature, there's not very much, just like in any other group. I mean, this morning, Dr. McCauley was saying, what can we do to have more research related to COVID-19, and why aren't nurses doing more research? I just want to present what was in the literature, not done by nurses, but it is, I mean, when you don't have anything, you take what you have. One of the first studies I came across was farm workers during COVID-19, and this was in the American Journal of Public Health. And they actually talked about how half of all Latino farm workers are undocumented. They live in poverty. They have no health insurance. They have little, if any, health care. And that this is a big need for all of us to do research related to migrant workers. Also, the number of Hispanic and Latinos that are deemed essential, and these are people that usually have high contact with risk factors, because they may be working as home health care workers or nursing homes. They could be working in housing services, nursing assistants, orderlies, construction, restaurants, and all of these areas are important to examine what we can do to help these groups. There's also problems recruiting minorities, I'll say Latinos, for clinical trials. Latinos don't want to be in clinical trials, just like any of these groups that we're talking with. And what do we need to do? When it comes time to immunizations, what do we need to do? Tenor this morning talked about how each of us have to be role models, and that we need to think about getting the immunization, and we need to do that. I think 3 or 4 months ago, it was a scary thing, but I think we're seeing that they're doing good work with the methodology, and they're holding the trials when they need to, and they're looking at the side effects. But we all need to be role models with that, and that's how we can help our groups. Pregnant women, Latino pregnant women. There was one study that 60% of all pregnant women that were hospitalized were Latinos that had COVID-19. And this is a big factor, again, with immigration status, that a lot of the women don't have health insurance, and their social determinants of health. I'm actually completing a study myself related to Latinos and COVID-19, and looking at the social determinants of health, their knowledge, and their risk factors. And if you can imagine, the more risk factors for social determinant of health, the less education they have and the less information that they have about COVID. That's just some preliminary findings. We're going to be doing some correlations around that. So some of the other things I think that we really need to work on, that everybody here, and I don't know, I think across the board, is mental health issues. I've heard many Latino nurses, especially in those areas where there's a lot of Latinos, that all they see are Latinos that are laying in those beds dying, and they just don't know how they're going to take it another day or another week or whatever. We hear many nurses say they're planning on leaving nursing after all this, or young nurses who are getting out, you know, these graduates from May or August or December that are graduating. What are they dealing with? How are they dealing with civility? All the things that were mentioned earlier about just not being nice to each other. The other thing, the long haulers, Dr. McCauley mentioned the long haulers this morning, and I think there is differences by race and ethnicity. And long haulers is when you continue to have symptoms, if you're not testing positive, but you continue to have all these symptoms. You may hear people call it brain fog or whatever, but it lasts a long time, and you're supposed to be over it because you've tested negative. And the last thing that nobody has mentioned today or at all is genetic research. There are a lot of implications related to genetics and COVID-19, related to immunology, different blood types, and genetic mutations. And these are documented in the literature. I'm actually a part of the All of Us research program, and they are actually doing research with COVID right now, looking at all the blood samples since December, and looking to see how the genetic variants may work. So I think there's a lot of possibility for people that are interested in genetics, and I know there's nurses out there that could do this work.
Thank you so much for that. As we start winding down, I think we have maybe 5 or 10 minutes, last two speakers. So we'll just go on in with you, Dr. Garcia-Dia.
Absolutely. So for the Filipino American community, I think my focus, and I agree with the previous speakers with regards to social determinants of health, and at the same time looking at the health literacy and reliable information sources for our community. To Alana's point earlier, Asians are considered minority models, right? But absolutely, there are some people that might speak English, but their health literacy is not what we consider to be at par. In fact, that's the reason why PNAA has supported the PCOR project, which is facilitated by one of our members from the University of Texas Health, because we wanted to make sure that the voices of our patients in the community are heard on what are really their health concerns. One of the participants shared regarding the accurate and reliable information on medications, treatments, and procedures. Some of them follow social media information like drinking lemon water instead of taking their own hypertension or diabetes pills because information becomes confusing for them. Older participants express interest in non-prescriptive treatment for their health conditions. And one even asked, how can we learn or get alternative non-prescriptive options? And this is all about health literacy. And I think that researchers could take this opportunity to partner with reliable professional organizations like us in NCEMNA, who are trusted in the community. Within New York City, our PNA New York have partnered with NYU Center for the Study of Asian American Health through Kalusugan, which means Health Coalition. And they have actually worked together in driving the All of Us research program here, working with faith-based community. At the same time, because of our reputation in facilitating this type of research, the Asian Pacific Islander American Health Forum had reached out to PNAA in facilitating the project First Line. And this is where, again, we look at trying to make culturally and linguistically materials that would really meet the infection prevention control with CDC and translating this in different language and dialects. And I think that's where majority of the focus will be from our end in terms of really driving health literacy and including ourselves in the data. Because why Kalusugan Coalition started way back in 2007 is because there's not much data on Filipino American health. All our data is lumped under Asians, and this is where we need to start looking at disaggregating data and considering ethnic minorities, racial identification of ethnic races within our own electronic medical record.
Thank you so much for that. And then Dr. Angasta.
Thank you. Thanks, Dr. Toney. I echo with Drs. Tom-Orme, Dr. Dawson, Cuellar, and Mary Joy Garcia with regard to what are needed, what factors are needed for research. With regard to Asian Pacific Islanders, our APENA national organization is working on a special issue with regard to COVID-19 pandemic. And one of the first of its kind initiative that we've done, and this is from Dr. Unok Im, is to do this event and to bring the APENA and other minority organizations on the spotlight and discuss the current issues and also the healthcare needs. With regard to conducting research studies, this is also an opportunity for Asian Americans Pacific Islanders to be included in clinical trials and also research that are needed with regard to mental health issues and also needs, particularly the nurses and also the AAPI's communities. Dr. Garcia-Dia mentioned about disaggregating the mortality and morbidity data are important for Asian Americans because these are not one group. Also looking at social media, the impact of social media with regard to discrimination, racism, and also microaggressions, and also social determinants of health. Thank you.
Thank you. Wow, I think that was some great information to take hold of as we think about research and what are going to be the next steps. I'm not sure, David, if we have any questions before I go on. I know we're winding down.
We do not presently have questions, but we certainly are inviting our audience to submit those.
Okay, so I do have another question from these long-standing experts and the authentic voice on their communities, researchers, etc. Is there anything that our panelists would like to share with future researchers as it relates to working with the populations that you represent? Any suggestions, any what you call them, pearls of wisdom that you may want to share? And I'm just going to let whoever wants to jump in first. I see Mary Joy is smiling. Does that mean you're going first?
Absolutely. I'm putting on my informatics hat. I heard a lot of speakers this morning with regards to information communication technologies, and I think this is where we could really see the importance of data, right, based on the BIKW framework. And it's about time that we start to utilize that data in existing database and looking at disaggregation and also combining data in comparing health outcomes, health needs of various populations, because that's the only way for us to move forward towards the genetic genomic component piece of it and really try to understand and root cause. Follow the data, follow the science.
All right. Dr. Dawson?
Yes, I'd like to add to that is that, there was a survey recently with the African-American population, and 79% of mostly Black adults said that systemic racism was a major obstacle to Black people achieving equal outcome with whites. And then 66 of that in the same survey said that will be about 2 out of 3 Black adults said that the government response to COVID-19 would be different if there was more whites dying than people of color. And another 65% said that most adults are not confident that this vaccine that they're coming up with has taken into consideration the need of Black and brown people. So with that in mind, one of the things I would like to push out today is that, and I think you almost started stepping into that space, both you and Norma, Debra, and that is, we don't need to see researchers when there's a problem. We need to see you before that time. We talk about trust again and building relationships. If you want to do research with our population, you got to have a relationship with our population. So one of the things that I would advise people to do, because I know right now that almost every grant that is coming out of NIH and others, they're asking people to include something about COVID. Well, if you're going to include something about COVID, and you just heard here today from the 6 of us that are representing, minority nursing associations, that our population are being impacted more than any other group. We're dying more than any other group. We're having post-recovery issues more than any other group. You need to have some Black and brown researchers on your research team. And we don't need to be invited after the fact. We don't need to be placed into your proposal as someone you're going to invite to the table once you get the grant. We need to be at the table helping you to create and develop the proposal. You have to reach out to us so that we can be engaged and help to guide your research. Because one of the things I believe already is we've already missed a great opportunity. Do you remember when we was dealing with Ebola and Zika? What did we do? We came up with a 1-sentence question. Everybody, your primary care physician, the ER, Have you been out of the country most recently? We should have had at least a 5-question survey by now on COVID that every person was being asked about. Not just have you been in contact, have you had a fever, had you had this or that, but there was some other significant questions that we could have been collecting data on relating to social determinants. How many people do we know were underinsured or had no insurance? How many people do we know? We keep saying about pre-existing condition, but what percentage of COVID patients by race and ethnicity actually had pre-existing conditions, and what were they? Were it obesity, heart disease, renal failure? Were they sickle cell? Come on, we have already missed a great opportunity for doing great research. And as you all can tell by my voice and expression, I'm on a soapbox because I think we missed a great opportunity as calling ourselves researchers, and we have not stepped back and done this correctly.
Well, I'm going to help you out with that. Dr. Norma, we're going to give you a minute
Okay.
because I see David, and I'm going to turn this back over to him. But I do want to say thank you very much for inviting us to be here. And maybe the next time we come, you'll give us a little bit more time, huh?
Thank you, give us a lot of time. I think we just
Yeah,
give
30
it
seconds,
okay.
Norma.
Okay, as new researchers, I want you to always remember to measure demographics. I can't tell you how many proposals I read over and there's no demographics. Make sure you include race and ethnicity. And remember, all of these groups are races, but Latinos. Latinos is an ethnicity. You can be Black Latino, you can be Asian Latino, you can be American Indian Latino, you can be Asian Latino even. So remember that Latinos is an ethnicity, not a race. Keep it separate. Also remember that there will be many, they say, and Tenor may know, I don't want to take anything away from Tenor, but there will be more pandemics in the future. We're probably going to see them more often. And just like Martha just said, we need to be learning from these, and we need to, Tenor did an amazing presentation this morning about what all nurses should be knowing and prepared, and all of us could be collecting data. So that's all.
Thank you.
Can I add something? So in my population, the American Indian Alaska Native, I would just say, know the community that you're working with. One elder once told me, we want researchers to come in and have coffee with us, to hang around our community, to get to know us first before they bring in their whole team and come in to do helicopter research. Because historically, people have come in as if they're flying their helicopter in, collected data, and off they go with their data, never to be seen or heard from again. So people are more astute about research now. They want to make sure that the research that's being done will be helpful to their community. So therefore, come in, learn about the people, know what their needs are, share with them, include them, train them, hire them as research assistants, work with students to train them on how to write a protocol, how to collect data, how to write for publication, the whole gamut. And that's what people want to see. And they're very cautious about any kind of genetic research. And so that's, it can be done, but it just takes a lot of work, a lot of working with locals to get through that.
Thank you for that.
Dr. Toney, 1 minute for we didn't mention a lot about telehealth, and now there is an explosion of virtual care and telehealth. I'm encouraging our members as well as colleagues to reach out to our communities, that how important it is to make an appointment with their healthcare providers, and not to be fearful, because there is telehealth and many of their insurances cover telehealth as well. Thank you.
I am on the front line in an FQHC, and that's really how we see the majority of our patients now, is through telehealth. David, let's want to keep us on time. Thank you again, everyone. Thank you so much.
We've done a good job today of staying on time. We don't want to break that record now. So thank you.